Hello again, my name is Dr. Betty Dube, and in this part of the endocrine system, I'll be talking about calcium and the parathyroid hormone. Just note that where the parathyroid hormone glands are located, and these are the glands that produce the parathyroid hormone, also known as PTH. So by the end of this session, you should be able to describe the epidemiology, etiology, and pathophysiology of parathyroid disorders as they relate to calcium, recognize the clinical features, identify the drug causes and links to vitamin D, calcium, and the PTH, as well as outline therapeutic management and monitoring. So just as a quick reminder, the calcium ion plays a role in multiple physiological functions in the body: skeletal and cardiac muscle contraction, synaptic transmissions, coagulation, apart from acting as a second messenger intracellularly to regulate cell division, motility, and signal transduction, essential for homeostasis. Around 99% of the total body calcium is stored in the bones, with only 1% of the rest in the extracellular calcium being available for essential metabolic functions. And of this, 50% in the extracellular fluid is bound to albumin, and it is the remaining ionized calcium that is biologically active. The calcium levels in the body are dependent upon the absorption from the GIT, turnover from the bones, and excretion from the kidneys. So parathyroid hormone, vitamin D, as well as magnesium levels play a role in controlling calcium levels in the body. So I think from this you can see that malfunction in any of these or quantities of any of these can cause an imbalance in this particular system. So the parathyroid hormone is secreted from the parathyroid glands, and it acts on hormone-specific receptors on target tissue cells. There are 4 parathyroid glands situated posterior to the upper and lower lobes of the thyroid. It acts on the renal tubule and tubular transport of calcium and phosphate, and stimulates the renal synthesis of 1,2,5-dihydroxycholecalciferol. That's really the chemical name of vitamin D. Low levels of iodinized or unbound calcium stimulate PTH secretion, whereas high levels suppresses secretion. Again, it's another negative feedback mechanism. PTH increases distal tubular resorption of calcium and decreases proximal and distal tubular resorption of phosphate, so that is a balance that occurs in the kidneys. So the 2 major cell types in the bone are osteoblasts and osteoclasts, just to remind you again of the effects of PTH on bones. Osteoblasts are responsible for synthesis of extracellular bone matrix and priming of its subsequent mineralization, while osteoclasts decalcify and digest protein matrix of bone, liberating the calcium. PTH stimulates osteoclast-mediated bone resorption and has an anabolic effect on bone, with an increase in osteoblast number and function. Vitamin D, in the form of calciferol, can either be derived from plant sources, D2 or egocalciferol, or animal sources, D3 cholecalciferol, or it can be produced in the dermis of the skin from cholesterol precursors. Vitamin D3 needs hydroxylation in the liver and kidney to get converted to the biological active form, the 1,2,5-dihydroxycholecalciferol. Vitamin D increases calcium as well as phosphate absorption in the GIT and influence parathyroid hormone-mediated resorption of calcium from renal tubules. So you can see how everything here is quite interlinked with regards to PTH, calcium, and phosphate as well. Again, that's just a summary of what I was talking about there, just in larger font. You can pause the video and have a read. Importantly for you to note the different types of vitamin D sources, but also activation is important to occur in the liver or kidney. So meaning if there's a malfunction, if the liver or malfunction in the kidney, there might be a potential imbalance of this PTH, calcium, and vitamin D homeostasis. So when we have hypoparathyroidism, also would present as hypocalcemia. It's a clinical state which may arise from either failure of the parathyroid hormones to secrete PTH or from failure of its action on the tissue level. Etiologies most commonly occurs because of surgery from thyroid disease, after neck exploration or resection of any adenoma causing hyperparathyroidism. So in the effort to treat hypothyroidism can occur. Hypoparathyroidism can occur. It's a mouthful there. Other causes include autoimmune disorders as well. And a few reports have identified acute symptomatic hypocalcemia and hypomagnesemia complicating the use of omeprazole and other PPIs. So patients become severely magnesium depleted and in this process acquire hypoparathyroidism. This is normally reversible once the offending drug is stopped. And in this case, somebody would be stopped on the PPI. Okay. In clinical manifestations of hypoparathyroidism are due to hypocalcemia. So there's a decreased levels of ionized plasma calcium levels that leads to increased neuromuscular excitability. Major signs and symptoms of hypocalcemia would include numbness and tingling in the extremities and around the mouth, muscle spasms in some people, seizure disorders, irritability can occur. Some people experience cataracts, and as well as there's a facial spasms on tapping of the seventh cranial nerve. Causes could be either hypoparathyroidism or pseudo-hypoparathyroidism, vitamin D deficiency, its malabsorption, insensitivity can cause it, acute or chronic renal failure, acute pancreatitis, chronic alcoholism, low magnesium levels, and could be drug-induced with drugs like PPIs. So investigations are really important in this case, and hypocalcemia associated with undetectable or low levels of PTH level is consistent with hypoparathyroidism. When investigating calcium levels, the total plasma calcium levels should always be corrected for any abnormality in the plasma albumin concentration using this equation here, or of course you can use an online calculator, and there's one I've put on a link here. Hyperphosphatemia is often present, and it's important to note that there are many other causes of hypocalcemia. There's also a phenomenon of pseudo-hypoparathyroidism, and this should be distinguished because it's associated with excessive PTH secretion and reduced target organ responsiveness. Drugs that may produce hypocalcemia include those listed there. You can pause the video to have a read. Okay. So those are the drugs again, just in larger font for you to pause and have a read. So in a few instances, some people would present with severe acute hypocalcemia and they would present with tetany, and this should be treated as a medical emergency. It is routinely treated with intravenous calcium gluconate, and the initial dose is normally 10 mils of 10% calcium gluconate that's given in a slow infusion, slow IV injection, preferably with ECG monitoring. And if the patient can swallow, oral therapy should be given. Further to the initial parenteral therapy, a 20 ml of 10% injection should be added to each 500 ml of IV fluid and given over 6 hours. Again, most NHS trusts will have their own protocols on how this is treated. With regards to chronic treatment, so a parathyroid hormone as a drug is not a practical option, because it is produced via recombinant human PTH and has been administered, and it has to be administered parenterally, so by injection. But the current high cost makes it quite prohibitive and inaccessible. So maintenance treatment of hypoparathyroidism is easily achieved via vitamin D preparation to increase intestinal calcium absorption, often in conjunction with calcium supplementation. Many preparations are available. We have tablets, capsules, oral injections, oral drops rather, and injections. So there are a few options. So we could potentially supplement with egocalciferol, which is vitamin D, but this is not recommended because it has a long pharmacological and biological half-life over 4 to 8 weeks to restore normal calcemia, and its effects can persist up to 4 months following withdrawal, so not ideal. So instead, we use calcitriol and its synthetic analog alpha-calcidiol. These are routinely used. Alpha-calcidol restores normal calcemia within a week, and its effects persist for only 1 week following withdrawal, permitting greater flexibility in dosage and in dosage manipulation. The usual dose of the alpha-calcidol is 0.5 to 1 microgram. Patients need to be closely monitored initially until stable normal calcemia is achieved, and thereafter at a minimum of 6 months. Okay. So next we'll delve into hyperparathyroidism, and this occurs when there's an increased production of the parathyroid hormone by the parathyroid gland. It can either be primary or secondary. So in recent years, some studies have indicated that primary hyperthyroidism occurs in around 25 cases per 100,000 of a population per year, and the incidences are almost 3 times more in women than in men, occurring in mid-30s to 50s. So the etiology here is due to the either development of a single parathyroid adenoma or sometimes hyperplasia of the 4 glands, occurs as part of the dominantly inherited multiple endocrine neoplasia syndrome. So it can occur as a part of that. And in several conditions are associated with secondary hyperparathyroidism, and this includes chronic renal failure and vitamin D deficiency. Chronic renal failure is the commonest cause. So if somebody has chronic renal failure, we'll be supplementing and checking these levels too. Early stages of the disease. In the early stages, there's a rise in plasma phosphate concentration causing stimulation of the parathyroid hormone release. And in advanced renal impairment, 1-alpha hydroxylation of vitamin D results in reduced intestinal calcium absorption, hypocalcemia, and further stimulation of the parathyroid glands, then thus leading to hyperparathyroidism. And then tertiary hyperparathyroidism does occur in a minority of patients with end-stage renal disease, for example. So primary hypothyroidism is related to effects of hypercalcemia itself and the effects of mobilization of calcium from the skeleton and excretion in the urine, with increasingly early recognition of the biochemical abnormalities of primary hyperparathyroidism due to automated measurements of plasma calcium. Most patients are identified at an early stage with mild or asymptomatic disease, which is really important in these kinds of imbalances. So signs and symptoms, again, are quite non-specific. Could be anorexia, weight loss, polydipsia, polyuria. Probably it sounds like some other disease we've just recently studied. Mental changes as well, poor concentration, memory, fatigue. Some people present with dyspepsia, nausea, vomiting, constipation. Some people present with hypertension, renal stones, deposits in the eyes, bone pain in some people, and pathological fractures. So quite non-specific as you can see here. So investigations is primarily due to biochemical abnormality as a result of that will show hypercalcemia and that the hyperparathyroidism. Phosphate levels are often decreased and PTH levels are either inappropriately normal in the face of hypercalcemia or elevated. In a patient with borderline elevation of calcium or in normal or only marginal elevated PTH, the benign condition familial uric hypocalcemia must be excluded. So further tests must be conducted. Urine calcium excretion is increased in primary hyperparathyroidism and low in familial uric hypercalcemia. So that could be the differential diagnosis between the two. So there are many other causes, included those listed here, drug-related malignancies, and sometimes when you have PHT levels that are undetectable because the normal parathyroid glands appropriately switch off production of PTH in the face of hypercalcemia. So the most common cause of symptomatic hypercalcemia in clinical practice is that associated with malignancy. So this diagnosis must always be excluded, and localization of the parathyroid tumors is required only in those listed for neck exploration. Most parathyroid surgeons request a neck ultrasound prior to performing neck exploration just to make sure this is ruled out. And this is what they could be done. Again, quite clinical and quite specialist, sort of out with our realm, but I thought I would include it here for our completion. So initial evaluation of patients with primary hyperthyroidism. So you have the blood test as listed here, you have the urine test, and you have the bone marrow density in some places. Then this could vary depending on your trust and what protocols they have in place. So just have a quick read here. So now when it comes to treatment, surgical removal of the adenoma or removal all all hypoplastic tissue is the only curative treatment for primary hypothyroidism, and studies have indicated that up to 50% of untreated patients with primary hypoparathyroidism show no deterioration over 5 years, but the longer-term effects on renal function and bone mass still remain unknown. So I thought I'd include here a visual summary from NICE that the primary hypothyroidism diagnosis. I'll also attach this on the lesson for you to have a read. It's a really good schematic representation of the measuring of the albumin-adjusted serum calcium, and then what happens if the levels, the numbers, what the numbers are, and what should be done next, and what kind of diagnostic pathway is followed. And this is from the NICE guideline for primary hypothyroidism. So treatment is by 25-hydroxy vitamin D replacement therapy, and this is recommended with patients with primary hypoparathyroidism having coexistent vitamin D deficiency to maintain levels greater than 50 nanomoles per liter. So it's quite small if you have a look at the quantity of this, but it's significant. Remember, all these work at the cellular level. And also by phosphate therapy, which is routinely weekly alendronic acid or monthly zoledronic acid, should be prescribed in patients with primary hypothyroidism, but who are not suitable for elective parathyroidectomy and who have evidence of osteoporosis on dual energy X-ray absorptiometry scan. So if that is confirmed, then they will be given the medications and not candidate for surgery. Again, surgical treatment, the main indication for surgical treatment is persistent hypercalcemia of greater than 2.85 millimoles per liter. And if they have symptomatic hypercalcemia, if they have renal impairment, renal stones, and progression of osteoporosis. And post-operatively, there will be a temporary hypocalcemia, which is called phenomenon called hungry bones is common. So in patients with bone disease, treatment with alpha-calcidol and calcium supplements should be started on the day before the operation. So this is important, again, an area where as pharmacy professionals we would be involved in making sure this happens prior to surgery. Around 10% of surgical treated patients experience permanent hypoparathyroidism. Okay. So here's the guideline for surgery in patients with hypoparathyroidism. So the age, that's the cutoff and recommendation, the BMD recommendations, renal function recommendations, serum calcium recommendations, and these are all important. Again, they may vary per NHS board you work in. So according to NICE, they have also primary hypothyroidism management here. Very good, again, flow chart. I really like these flow charts. They give you exactly what should be done to each patient. Again, it's a guideline, it's a recommendation, not written in stone, and it will vary case by case, patient by case, and sometimes trust by trust. Again, this will be uploaded for you to have a look. And then monitoring of the people with primary hypothyroidism is important. I thought I would include this here. That guidance, it's a treatment and monitoring. It's a two-page nice summary. I thought I would include here as well. So important here. It does recommend like assessment of cardiovascular risk and fracture risk is important in all people with primary hypothyroidism. And this is something we could certainly be involved with. And also making sure this is followed. So monitoring will be BMD every 1 to 2 years, serum calcium every year minimum, and renal function. EGFR and serum creatinine every 12 months. So the treatment of hypercalcemia is a common medical emergency, and it must be corrected while investigations are ongoing. The cause must be identified. So in practice, rehydration in parenteral biphosphonates, for example, pamindronate 60 to 90 milligrams into 50 mils of normal saline over 60 to 90 minutes should normalize calcium over 72 hours in most patients. Again, the most trust will have a guideline on the best way for this to be treated. And for those of you who work in hospital, you may have come across this. Again, there's the treatment of hypercalcemia, just a snapshot there. and what I just said, the normal saline, then reduce. So you have to increase urinary calcium excretion because we're trying to treat hypercalcemia. We want to reduce bone resorption. We want to reduce gastrointestinal absorption, and we also want to chelate any extra calcium, and this is how it will be done. Again, thank you again for listening, and please post any questions related to this part of the lesson on the module page. Thank you.